Hello everyone. I'm presenting prevention of mother-to-child transmission of HIV. That is PMTCT, family-centered approaches. Introduction. The HIV is a pathogen that we all know causes AIDS, that is acquired immune deficiency syndrome due to the immune system breakdown or weakness. According to WHO, that is 2016, by 2015, 36.7 million people were living with the virus. 2.1 million new infections were reported, and unfortunately 1.1 million were lost during just 2015 alone. The HIV virus can be vertically transmitted. That means from a pregnant mother to her fetus or newborn. It is either during pregnancy, during childbirth, or when the baby is already out and is breastfeeding. Hence, there is a need for a family-centered approach to prevent its transmission from mother to the baby. Problem statement. In Africa, where the burden of HIV is the highest, some of the prevalences are up to 40%, and mostly it is women who are affected. And you know that in many African countries, 55% of HIV-infected adults are actually women. This burden not only affects the women, but their babies, their families, their community, and the entire health system. A lot has already been done by individuals, by governments, by the international community to try to prevent the transmission of HIV from mother to the babies. However, the HIV rate has remained persistently high, partly because the scope of the PMTCT has been narrow, focusing mainly on the component 3 of the preventing vertical transmission, rather than a comprehensive services, which would include the entire family. This is according to WHO. And that has been the focus of my presentation here. Now, what is the difference between a PMTCT and a family-centered PMTCT? A family-centered approach to PMTCT is an important preventive measure for pediatric HIV infections and improves family health. Many different publications try to prevent a variety of components of the family-centered care. When I looked at several publications. I narrowed them down and summarized them into four. Number one is prevention of HIV infection in women of reproductive age. If we prevent HIV infection in women of reproductive age, which means many children will be born without HIV infection. Number two, avoiding unintended pregnancy among HIV infected women. If a mother knows she's HIV infected and doesn't want any child, then it's better to prevent, use, say, maybe condoms, other barrier methods rather than getting a child which is not needed and becomes HIV positive. Three, preventing HIV infection from a woman to her infant. This one has also three levels. We have prevention during pregnancy, prevention at the time of birth, prevention after birth, say during breastfeeding. Lastly, follow-up, care, support, and treatment to HIV-infected women, their infants, and the families. Here, there are actually a lot of interventions. The care here can be psychosocial support. It can be a follow-up for adherence. It can be forming groups, the HIV Anonymous. It can be a financial support. So the last one is quite broad. It covers, as I said, a lot of interventions. What are the objectives of this presentation or of the study? One was to review all the available literature on family-centered PMTCT as early as 1990s. Although I put here 2010 as per the review document, but I did actually up to 2017, in other words, to date. Two, to describe findings and barriers to the delivery of family-centered PMTCT. Yes, it is good to incorporate the entire family, but what are the challenges related to this? Three, identify a number of promising new directions that may achieve more holistic services for children and their families. Since different partners use different approaches, it's good to come with a unified approach to the family-centered HIV care. Which method did I use? This was a review. I basically looked at available publications, retrieved them from the various websites, analyzed them, listed the common interventions, which of them worked well in which locations. In total, up to 403 abstracts I looked at, and a number of them had common things which show the promising outcomes. The outcomes which I found were the following. One, most common family-centered interventions included counseling, testing, and provision of antiretroviral treatment for infected pregnant women. Safer infant feeding practices, especially the exclusive breastfeeding, knowing that mixed feeding will increase the risk of HIV infection after birth. Or exclusive bottle feeding without breastfeeding. Integration of early childhood development services, especially immunization and early childhood education. Preventing HIV infection in women of reproductive age. Avoiding unintended pregnancy among HIV-infected women. Provide follow-up and care, support and treatment for HIV infection. Before we come to conclusions, in the edited version I had talked of, we have the barriers. One of the barriers is that there is limited data in relation to family-centered PMTCT care, which was a limitation. Two, the available PMTCT services do not actually capture HIV testing among infants until 18 months. Three, the comprehensive care is quite expensive. For you to include the entire family is quite expensive in terms of the personnel, in terms of the time, and say the resources. So it's quite expensive. So it's a barrier. In conclusions, family-centered preventive measures can be effectively integrated within programs. We can integrate it within the health system. We can integrate it within the school health. We can integrate it within outreach services. Two, PMT services can be expanded to address the needs of the entire family instead of focusing on the mother and the newborn. How about an older child?
Thank you, Ratib. Thank
Who
you
has
very
had
much for your
HIV
wonderful
infection?
presentation.